Hello everyone, my case presentation is about fatigue. Fatigue is a sensation of exhaustion during or after usual activities or a feeling of inadequate energy to begin these activities. For many patients, fatigue is related to a known severe illness or organ failure. These are the contents of my video. One is the differential diagnosis. Second is patient history of present illness. Third is the past medical history. Next is the review of systems. Number five is physical examination and test results. Seven is the X-ray imaging and the 12-lead EKG. Number eight is the diagnosis, and the last one will be my admission orders. I will let you take a look at the vindicates, the vascular, infection, neoplasm, drugs or degeneratives, idiopathic, congenital, autoimmune, trauma, the endocrine, and the psychosocial. As you can see, I bolden the differential diagnosis. My prioritized differential diagnosis are number one is a STEMI, two is a thoracic or abdominal aortic aneurysm with dissection, number three is sepsis, fourth is blood dyscrasia, and number five is depression. And this is the history of the patient's present. The patient has a past medical history of GERD, past surgical history of EGD. He has a family history of diabetes with a father. His social history are non-smoker. He is positive for alcohol use with about two mixed drinks in the evenings, but negative drug abuse. This patient has no known drug allergy, and his home medication is pantoprazole 20 milligrams POD daily. For the review of systems, constitutional, positive for fatigue times 1 week, no fever or chills. For hearing, um, or HEENT, denies changes in vision or hearing, no sore throat or trouble swallowing. For cardiac, denies palpitations, denies chest tightness. Respiratory, no cough, positive for dyspnea on exertion. Abdomen, denies nausea, vomiting, abdominal pain, no hematemesis or melena. Genitourinary, denies any recent changes in urinary habits, no hematuria or dysuria. For neurologic, positive for lightheadedness when getting up suddenly, negative syncope, musculoskeletal, no myalgias, no deformities. For the hematologic, negative for bruising, bleeding, or clots. And for psychosocial, denies depressed mood or anxiety. For the physical exam, generally the patient has no acute distress. Vital signs, you have a temperature of 36.2, pulse of 82, respirations of 18, blood pressure of 124/76, SpO2 of 94% on 2 liters per nasal cannula. The patient is normocephalic, atraumatic, moist mucous membranes, perla at 3 millimeter, sclera clear, non-icteric, oropharynx clear. The neck has no JVD, no carotid bruit, no thyromegaly, cardiovascular, regular heart sounds without murmurs, rabs or gallops, pulses +2, radial DP, PT, positive 2 on femoral pulses. Respiratory clear throughout all lung fields, no accessory muscle use, in the abdomen soft, abdomen, no tenderness, bowel sounds are present in all four quadrants, no organomegaly. Musculoskeletal, full range of motion to all extremities, no edema. For neurologic, alert, oriented times 4, sensation to all extremities. In the lymphatics though, he has a palpable enlarged tender lymph nodes in the bilateral groin area. In tegumentary, it's pale and warm. For the CMP result and magnesium, if you look at it, they're all within normal limits. On the CBC with differential result, the WBC is elevated, so patient has leukocytosis. Hemoglobin hematocrit went down, but for me it's not concerning. Platelet is also on a low side, wherein he has a thrombocytopenia. Closely, you will see that the MCV is elevated, which means that the patient has an RBC, which is large and indicating of macrocytic anemia. The urinalysis of the patient is also unremarkable. However, the serum folate is low, which occurs and causes the body to produce abnormally large red blood cells that can't function properly. The chest X-ray result has a final impression of mediastinal lymph adenopathy. My next slide is the 12-lead EKG. The rhythm of this 12-lead EKG, it's irregular. Some QRS are not followed by P waves. So I would say that this is a normal sinus rhythm with PACs. My diagnosis with this case study is with the presentation of the patients, his chief complaints, the x-ray result, the blood result, I would diagnose this patient as having macrocytic anemia. However, with elevated WBC, he might also have a ongoing infection with mediastinal lymph adenopathy and enlarged painful lymph nodes on the groin. I would try to rule out infection and blood dyscrasia. I read in blood cancer articles that with lymph adenopathy, it's painless. However, it can be painful if the patient is a drinker. My admission orders are this patient um, is diagnosed as having macrocytic anemia, rule out blood dyscrasia. I'm going to admit him inpatiently. He has no known drug allergy. He will be full code, vital signs per protocol per unit. He will be hooked to a telemonitor. The um, oxygen level will be maintained above 92% with 2 liters nasal cannula oxygen. He will be on regular diet, however, NPO after midnight. I will order hydroxycobalamin 1000 micrograms IM every other day for 1 week, then once weekly for 4 weeks, then monthly until recovery. Folic acid 1 milligram IV once daily. I will I will prescribe the same home medication which is pantoprazole 20 milligrams PO daily. For VTE prophylaxis, I will use heparin 5,000 units subcut every 8 hours since patient will be admitted inpatiently. I will start also Socin 3.375 grams IBQ 8 hours, but before that uh, blood culture must be drawn first because of the WBC which is elevated. Tylenol 650 milligrams PO Q4 hours PRN for fever and pain, and a stool softener which is Colase 100 milligrams PO daily and PRN. For IV infusion, I will utilize one banana bag. And for my laboratory test, I will order for peripheral smear stat, reticulocyte count stat, thyroid panel, blood culture, CBC with differential for 5 days, CMP daily for 5 days. I will also order a COAG panel, LDH, and hepatic panel in the morning. For the diagnostic test, 2D echo, EKG on admission, and if patient is complaining of chest pain, fluorodeoxyglucose or PET scan, abdominal ultrasound, lymph node biopsy, bone marrow aspiration with biopsy in the morning. His activity will be bed rest, and I would consult hematology. This is the end of my slide.